Good morning, dear friends. Today we start our lectures in neurology. And the topic of today's lecture is sensory physiology and pathology. But previously, I want to revise with you some aspects of physiology, morphology, and anatomy of the nervous system. This is absolutely familiar information for you. Main functions of the nervous system. The first one is interaction of the human body with surrounding environment. The second function is maintaining of the visceral homeostatic functions, regulation of all inner body processes. And the third function is integration of first and second functions, that is existence of the human organism as a unity. According to these main functions, we can divide our nervous system into two big parts. The first one is somatic nervous system. And somatic nervous system is responsible for the first function, interaction of our organism with surrounding environment. And the second functional division is the autonomic or visceral or vegetative nervous system, which is responsible for the second function, the maintenance of all our inner process, work of all our inner organs, and our metabolism. Some words about anatomy, histology, and morphology. The morphologic unit of the nervous system is neuron. Every neuron consists of two parts, the body cell and extremities. We know two modalities of extremities. The first one is axon. Axon is always only one, and axons pass information from the body cell outside. And the second modality of extremity of neuron is dendrite. Maybe none of them, maybe one, two, several, and they always give information inside to the body cell. On this picture, we can see axon with myelin sheath. Function of myelin sheath. Myelin sheath is dielectric, isolator, and provides speed of impulses. In myelinated axons, their speed may be very, very, very high, and even 80, 90, even 100 meters per second. It's very important in the somatic nervous system, you see. And in the vegetative or visceral nervous system, we can see non-myelinated axons without myelin sheath, and speed in these fibers is very slow, 5, 6, 7 meters per second. It's okay for the maintenance of permanent work of inner organs, for example, in the vegetative nervous system. Okay, anatomically, we can distinguish nervous system into also two big divisions, the central nervous system and peripheral nervous system. The central nervous system consists of brain and spinal cord, and all other parts of nervous system compose the peripheral nervous system. There are spinal roots, peripheral nerves, cranial nerves, and plexuses. Let's revise main parts on these pictures. I will show off the brain and spinal cord. The brain, this is a convexital or superior lateral surface of brain. This is the cortex, and the cerebellum and brainstem below. We can distinguish on this picture main four lobes of brain. They are frontal, parietal, occipital, and temporal lobes. This is sulcus centralis or Orlandi. This is sulcus lateralis or Silvi. We can see precentral gyrus, postcentral gyrus, and pole of the frontal lobe. This is the coronal view. We can see frontal, parietal, and occipital lobes on these pictures. Okay, this is basis of brain, and we can distinguish the structures. The frontal lobe, bulbus olfactorius, optic chiasm, optic nerve, midbrain, pons varolii, medulla oblongata, cerebellum, temporal lobe, occipital lobe, and yellow cranial nerves. So, this is inner or medial surface of brain. We can see the cortex, frontal, parietal, occipital, temporal lobes, and corpus callosum. Corpus callosum connects two hemispheres, left and right, and main parts of brain stem. This is subcortical area. The name of this part is diencephalon, and the structure in the center is thalamus opticus. This is hypothalamic region of third ventricle, and pituitary gland, hypophysis below with infundibulum, and this is pineal gland or epiphysis. So, thalamus, hypothalamus, epithalamus. The next part of brain stem is mesencephalon or midbrain. We can distinguish lamina tecti with colliculi superior and inferior, and cerebral peduncle, and between them we can see cerebral aqueduct connecting third ventricle and fourth ventricle. This is medulla, pons varolii and medulla oblongata, and posteriorly the cerebellum. I show on this picture main parts of brainstem, subcortical area, diencephalon, then mesencephalon midbrain, then pons and medulla. This is the next part of the central nervous system, the spinal cord. We can see gray matter like butterfly and white matter. Why white? Due to presence of myelin sheath. Myelin sheath is white, has a white color. And so, if we say about gray matter, we can see posterior horns, they are sensory, and anterior horns. They are functionally motor. And if we say about white matter, this is pathways of spinal cord, and they compose funiculus, posterior, lateral, and anterior. Funiculus or columns, sometimes we say columns. So, we revised information about some aspects of anatomy, morphology, physiology, histology of the nervous system. And now we start the lecture, our first lecture, sensory physiology and pathology. Okay, the functional unit of the nervous system is reflex, the morphological unit. Neuron, the functional unit, reflex. Every reflex consists of 5 basic parts, you know. Receptor that receives irritation from inner or outer space. Afferent centripetal pathways carry information to the center. The center. Efferent centrifugal pathways carry information from the center and working organ, muscle as a rule. The initial basic part of every reflex that determines it is reception. That means perception of the inner and outer information. So, definition: sensory function or sensation is an ability of living organism to perceive irritation coming from inside to outside and to respond in differentiated kinds of reaction. We know 3 main parts of perception according to this: receptor, afferent pathways, and cortical center. Today we will describe 2 first parts of perception: receptors and afferent pathways, and then pathology. Receptors. Classification and types, modalities of receptors. The first modality is exteroreceptors. Sometimes we can say without re. Exteroceptors. This is the same. We can say, neurologists, exteroreceptors, exteroceptors, proprioreceptors, proprioceptors. Doesn't matter. They lie on the surface of human body, in skin and mucoses. There exist 2 types of exteroreceptors. Contact receptors, when there is a direct contact between the source of irritation and a receptor. For example, when we touch skin. And distant receptors, when the source of irritation lies in a distance from a receptor. Examples: hearing, sight, vision. The second modality of receptors, proprioreceptors or proprioceptors. They lie deeply in tissues, in muscles, joints, ligaments, periosteum, and they provide information about body position and movements and extremities position and movements. And the third modality, there are interoreceptors. They lie inside human body in organs. So, according to these modalities of receptors, we have similar modalities of sensation or types of sensation. The first one, exteroreception, or sometimes exteroception, the same, or superficial sensation, so perceived by exteroreceptors. This kind is subdivided into pain or pin-prick sensation. We touch 2 or 3 times the skin of our patient with special pin and ask about patient sensation. And we have to make out the extent of abnormality according to dermatome distribution. The second modality, this is temperature sensation. We can use hot or cold objects or tubes, but always we use our hammers, neurological hammers, with metal or wooden parts, sometimes plastic handle, for example, and this absolutely can suit this purpose. The third modality, this is tactile or light touch sensation, tested by using wisp or cotton wool, not used in practice because it is always preserved when pinprick and temperature sensations are normal. Very important to compare sensation on both sides. When we touch the skin, we don't know what our patient can feel. This is absolutely subjective. If he says or she says yes or no, we absolutely cannot appreciate this. It's subjective. So we have to compare with symmetrical part of skin. The patient is asked whether the pinprick feels the same on both sides and whether the sensation is dull or sharp. And this is like we can map out the distribution of sensation abnormalities. The second big group of modalities, this is proprioception or proprioception or deep sensation, perceived by proprioceptors. This one is subdivided into the following. Vibration sense. The tuning fork is used. It's put on body prominent, for example, processus styloides of radius or ankles. Ask the patient to compare the vibration on the symmetrical left-right sides, like on the picture. A joint position sense is tested by moving the terminal phalanges of the patient's fingers, then the toes, up or down a few degrees. If the patient cannot identify these tuning movements with eyes closed, larger up and down movements are tried before testing the next most proximal joints. For example, testing their ankles if toe movement is not perceived. And the third big group of sensory modalities, combined cortical sensation, or sometimes we say complex sensation. Why combined to complex, I will say a little bit later. Modalities. Stereognosis, that is recognition of an object to the touch. We ask the patient to close his eyes, then we put a familiar object, coin pen key, into his palm. The patient has to recognize the object. In case of pathology, we say about stereognosis. Graphesthesia, that is the ability to recognize numbers or letters traced out, which we write or draw on the skin, for example, circle, plus, cross, minus. 2 points discrimination. That is the ability to discriminate two touches when simultaneously applied to the symmetrical parts of the skin. The shortest distance is on the finger, 5 millimeters apart, 4 centimeters, for example, on the legs. The biggest one is on the back and buttock skin, maybe 6 centimeters apart, for example. The fourth modality, accurate touch or localization sense. This is the ability to indicate the point of the doctor's touch. 2 point discrimination and localization senses are used seldom, but 2 first modalities we use every day in our practice. I want to say why these modalities of sensation are complex or complicated. Sensation is complex, consisting of several modalities, including our somatosensory senses, like tactile, like touch and pressure, proprioception, temperature and pain, and also our 4 special senses, including vision, hearing, smell, and taste. For example, in case of stereognosis, we always use several modalities of somatosensory sensation. And also, very important to understand, comprehension of these 4 senses presupposes the participation of the cortex. To identify an object, the patient must have an image of it in the cortex. When a baby is born, he has got some simple types of sensation, pinprick or pain, temperature, so on. But he cannot recognize whether the object is a pen or key. As a result of his life experience, the images of certain objects or their characteristics are formed and used. The fourth big group, this is interoception or interoception. That is the information received from inner organs. In normal condition, we don't feel our stomach, heart, lungs. The pain is a signal of some abnormality in our body. Some words about the second anatomical part of reflex, about pathways. So, we said we have two modalities of sensation, superficial sensation and deep sensation. So we have two modalities of anatomical pathways. Tractus spinothalamicus, the pathways of superficial sensation, pain, temperature, partly like touch, and also dorsal column pathway, pathway of deep sensation, joint position, vibration, and also partly light touch. I want to compare these two modalities of pathways on this picture. So, this is spinothalamic tract of the superficial sensation. Our dendrites receive information from receptors, from the skin, for example, when we touch the skin, and pass information to the first-order neurons. First-order neurons, for all modalities of sensation, remember please, this is a rule, all modalities of sensation, all pathways have first-order neurons in the spinal ganglion. Axons of first-order neuron enter the spinal cord and terminate on the second-order neurons, which lie in the posterior horn. Axons of this neuron cross the midline and then form in the contralateral funiculus lateralis or column lateralis ascending pathway which goes up to the thalamus opticus, and third-order neurons of this tract lie in the subcortical area in the thalamus opticus. Remember please, thalamus opticus is a subcortical center of all sensory modalities. And then we have also thalamocortical tract, and this tract terminates on the fourth-order neurons, final neurons in the cortex, in the pons central gyrus, and neurons of cortex can give information about touch of the skin. So, 3 neurons in spinothalamic tract: spinal ganglion, posterior horn, and thalamus opticus, and then thalamocortical part of this tract. If we say about deep sensation, for example, we flex the knee joint. Dendrites receive the information about this flexion and pass this information to the first-order neuron in the spinal ganglion. Axons of these ganglion cells enter the spinal cord, avoiding great matter, avoiding posterior horn, just immediately in posterior columns of funiculus, form 2 ascending pathways, gracilis and cuneatus, or gall and Buddha ascending pathways, which terminate on their goal and Buddha nuclei in medulla oblongata. And axons of these second-order neurons in medulla oblongata cross the midline just here in medulla oblongata, and together with spinothalamic tract go up to the thalamus opticus. You know, thalamus opticus is subcortical center of all sensory modalities. And then we have thalamocortical tract to the post-central gyrus. So you can see first-order neurons and subcortical neurons lie on the same positions, on the same locations, but second-order neurons have different location. In case of superficial sensation, in posterior horns, in case of deep sensation pathways, Golden-Burdach pathways, in medulla oblongata. Okay. The gracile funiculus goal is carrying all the information from the lower half of the body, legs and trunk, while the cuneate folliculus Burdach is carrying information from the upper half, arms and trunk. Okay, now the next part of lecture, disorders of sensation or sensory impairment, and we start from semiotics. Negative symptoms: hypoesthesia, decreasing or loss of feeling. Anesthesia, we can say in Latin, aesthesia, in English, anesthesia, lack of feeling. Analgesia, loss of pain sensation. Term analgesia, loss of temperature sensation. Dysesthesia, wrong sensation. For example, the touch of hot object is perceived as painful. Very interesting phenomenon, sensory ataxia. Ataxia is disbalance. Latin word of ataxia means disbalance. Maybe cortical ataxia, vestibular ataxia, cerebral ataxia. In case of sensory ataxia, is result of pathology of proprioception. Impairment of deep sensation, proprioception, causes sensitive ataxic gait due to of impaired joint position sensation. The gait appears more normal when the eyes are open. With closed eyes, the gait is worse. The patient falls to one or both sides and swings in Robert's position. The gait is broad-based and reeling, like sailor's gait or drunkard's gait. This patient is walking with closed eyes, and you can see ataxic gait
back towards me.
With closed eyes. With open eyes, he will be better.
Okay, that's good. Okay, turn. Okay, that's enough. Okay.
Positive symptoms: hyperesthesia, increase of feeling; paresthesia, feeling of pins and needle sensation or burden feeling without irritation, without touching object. You see, in English, paresthesia, hyperesthesia; in Latin, paresthesia, hyperesthesia. And pain is also pathology of sensory system, the result of sensory fibers irritation. A very interesting phenomenon, causalgia, intense, continuous, burning pain produced by an incomplete peripheral nerve injury. Touching the limb aggravates the pain, and the patient resents any interference or attempts at limb mobilization. The skin becomes red, warm, and swollen. Causalgia only occurs with damage to peripheral nerves containing a large number of sympathetic fibers and responsive part to sympathetic blockade, pharmacological or surgical. What nerves can give causal G? Trigeminal, medianus, and ischiaticus. And now, please, next part of our lecture, types of sensory impairment. The peripheral type, impairment of all kinds of sensation in the autonomic zone of impaired nerve plexus spinal root innervation. The pattern of the sensory deficit aids lesion localization, nerve root plexus. Examples, please. Peripheral type, neural, mononeuropathy. In this case, nervus ulnaris. We can have pathology of all sensory modalities distally to the level of cut of lesion. In the autonomic zone of this nerve innervation, like ulnar nerve pathology on the picture. In this picture, you can see spinal root L5 is damaged, and we also can have pathology of all sensory modalities in the autonomic zone of this root L5, in this case, innervation. This is peripheral type also. Brachial plexus is affected, and loss of all sensory modalities in the autonomic zone of this plexus innervation, like on the picture. A very interesting disease, shingles. And this is varicella zoster viral infection. Shingles is a viral infection that causes a painful rash. Although shingles can occur anywhere on our body, it most often appears as a single strip of blisters. Shingles is caused by the varicella zoster virus, the same virus that causes chickenpox. After you've had chickenpox, the virus lies inactive in nerve tissue near your spinal cord and brain. And for example, in spinal ganglion or sensory cranial nerves ganglion, for example, trigeminal ganglion. So, spinal ganglions are affected and trigeminal ganglion can be affected. Years later, the virus may reactivate as shingles. If the rash has appeared, identifying this disease requires only a visual examination, since very few diseases produce a rash in a dermatomal pattern. So, in this case, for example, we know this is level TH3 because mammillary line TH4. This is TH3. So, the affected spinal ganglion is TH3 spinal ganglion. On this picture, we can see development of the shingles rash. The painful vesicles eventually become cloudy and darkened as they fill with blood crust over within 7 to 10 days. Usually, the crusts fall off and the skin heals, but sometimes after severe blistering, scarring and discolored skin remain. On this picture, this is very awful for the patient. Geminal herpes zoster with uveitis and keratitis on the picture. Herpes zoster may have additional symptoms depending on the dermatome involved. For example, herpes zoster ophthalmicus involves the orbit of the eye and occurs in approximately 10 to 25% of cases. It is caused by the virus reactivating in the ophthalmic division of the trigeminal nerve. Types of sensory impairment. Type number 2. The polyneuropathic type. Sensory loss of a SOX and gloves pattern. Both superficial and deep sensation are affected due to multiple damage of peripheral nerves of distal parts of extremities. It may accompany exogenic and endogenic polyneuropathies, and also hereditary. Exogenic, more often alcoholism and intoxications. Endogenic, more often diabetes mellitus, maybe nutritional, hepatotoxic, etc. Please remember, polyneuropathy, pattern like socks and gloves. The next type of sensory impairment. This is conductive type. Impairment of all sensory modalities below the level of damage in brainstem or spinal cord. For example, in this case, the brain level of pathology, maybe spinal level of pathology, maybe brain stem level of pathology, and below the level of lesion of pathways, we can see pathology of sensation. And one more very interesting type of sensory impairment, syringomyelintic or dissociated type. Why dissociated? Due to the damage of spinal posterior horns, loss of pain and temperature sensation with the retention of other senses, deep sensation, occurring in a cape-like distribution. So posterior horns are affected. You remember different location of second order neurons in pathways of superficial deep sensation, and only superficial sensation has second order neurons in posterior horns. And so this is a dissociated type of sensory pathology with normal deep sensation but affected superficial sensation, pinprick, pain, and temperature. Painless burns are a classic sign. Syringomyelia is a result of pathological development of spinal contact atoll. The cavitation appears inside the spinal cord, normally in the place of posterior horns. I want to show to you MRI of spinal cord with cavitation inside the spinal cord on the cervical level. So big cavity. 1, 2, 3, 4, 5, 6 vertebrae long. And this is on transversal view. Multiple cavitation on the cervical part. T1, T2 pictures. This is the scoring after painless burn on the back of this patient with syringomyelia. Syringo, syringa, Latin, English. One more very interesting phenomenon. This is Brown-Séquard syndrome, a stage of extramedullary tumor growth. This is pathology of half on this side, on this picture, left side, half of the spinal cord on this level. On the ipsilateral side, we have loss of proprioception. Contralaterally, we have pathology of superficial sensation. So, cross of midline of the superficial pathways is on the level of spinal segments, and cross of the superficial sensation, Goldenburg pathways, is upper in the medulla oblongata. So we have very interesting phenomenon when half of spinal cord is affected, dissociated type of sensation loss ipsilaterally and contralaterally. And one more slide about thalamus opticus pathology. This is symptoms of 3 hemi. You know now thalamus opticus is subcortical center of all sensory modalities. So in case of thalamus opticus pathology, we have 3 hemi symptoms: contralateral hemianesthesia, contralateral hemianopia, a loss of contralateral visual fields, contralateral hemiataxia, sensory, you see. And also patients can have contralateral thalamic pain, burning, diffuse, and exacerbated by the touch of clothing like causal cheer. Thank you for your attention.